Welcome to another recorded edition of Cracking the IR Code. I am Stacie Buck, President and Senior Consultant at RadRx. I know it has been a while since I did a recording. I took some time off from doing social media around the holidays and intended to start back up again in January with doing these case studies via YouTube, and January and February were just absolutely insane schedule-wise. I had a lot of projects that I was working on simultaneously, but now I am back and I do want to get back to my original plan where I wanted to record a case study every other week. So not weekly, but at least every other week. In the meantime, I have been posting cases without recordings on Facebook and also on LinkedIn, but I would like to get back to the recordings and then also sharing the documents with you from the recordings on a more regular basis. So let's go ahead and jump into the case that I've chosen for this particular session. This is for an angioplasty and stent, excuse me, of a popliteal stent graft and a thrombolysis procedure. So first, we're going to take a look at the indication and the procedure steps just to get a feel for what we're going to be looking at. So we have a 79-year-old male who has a history of a right popliteal aneurysm, and he's status post-stent grafting. And then since that time, the graft has clotted twice. And then the patient was treated in an outside institution for that. He now presents with a painful right foot and dusky discoloration of several toes. So we have two clinical indications in the history. We have aneurysm, and then we have a clotted graft. That's in the history. So we're going to need to look further into the details of the report to determine what we're treating, whether it's going to be the aneurysm or whether it's going to be occlusive disease, because that is going to affect the coding. That's why it's so important to read that history for the patient. So then quickly, the procedure steps, we see that the physician gains access initially at that left common femoral artery. Then from there does selective catheterization and imaging, right common iliac, right common femoral. So we see imaging done of that right lower extremity. Physician has a second access site. Okay, so we're potentially assigning catheterization codes, possibly for two sides. We don't know until we get into the details of the procedure, or possibly one of them. Then we see that there is an angioplasty with stent done in the right popliteal and the stent graft. And then we see that there's a TPA infusion overnight, and then the follow-up post-thrombolysis of the right lower extremity on the following day. So this gives us an idea of the codes that we are looking at. We're looking at our stenting codes. We're looking at our thrombolysis codes. So let's go ahead and jump into this report and see what we have. So we look at the first step here where we see access was done at that left common femoral artery. That's the first part that I have highlighted there. Let me pull up my little pen here and zoom so I can actually annotate this drawing. Why is it not letting me do it? Here it is. Okay. Zoom likes to do updates and change how things display and where they display. So it doesn't always work the same exact way when you go back into it. Okay. So I've got my little tool. So first we're starting with our access at the left common femoral artery. It's not going to be a straight line. I apologize. Hard to draw with a mouse. So we start with our initial access. So you'll see, like I've done with other cases, is I actually am walking you through the progression of the catheterization codes at each step of the procedure. So you can see how we move from one catheterization code to another. So of course, anytime you first start an access in an upper extremity or lower extremity, you're going to begin with code 36140 for your non-selective catheterization. But then after that, it's going to get bundled with other selective catheterization codes. You wouldn't report that, nor would you report it with a 36200 when the catheter goes to the aorta. So from there, the catheter goes, it says it goes into the distal abdominal aorta, and then it was used to select the origin of the right common iliac. So at that point, we had a first order catheterization, a 36245. That's why the 36140 got bundled. But here you'll see that the catheter work ends up getting bundled, or at least the 36245 ends up getting bundled, because the catheter gets moved into next the right common femoral artery, which is a second order 36246. So that's why that right common iliac got bundled. But then you notice I also crossed out the 36246 because this is about to get bundled in the next paragraph with what we're going to look at for this procedure. So in the first paragraph, we see that there was a study of the right lower extremity, which I have tagged with 75710 for that right lower extremity imaging there. Then from there, in the next paragraph, we see that the physician is now placing a balloon catheter. Okay, the balloon catheter was passed and positioned across the mid-popliteal stent graft for balloon angioplasty. The balloon catheter was then removed and a follow-up arteriogram was obtained showing only minimal improvement. So at this point in the procedure, we had a 37224, an angioplasty of that particular vessel. Now, what you don't see here in this paragraph is you don't see the findings documented in this paragraph from the right lower extremity imaging. When we get over to the second page, you're going to see that the physician documented that there was a stenosis, and that's what tells us that we're going to use our lower extremity revascularization codes. So we started with a 37224. So why did that change? Well, in the next paragraph, the physician is now gaining a new access on the right side, and this is an antegrade percutaneous access of the right common femoral artery. So initially the access was at the left common femoral, catheter was moved across the bifurcation over into the right extremity, contralateral retrograde. Now the physician is going directly into the right extremity with this antegrade approach. And then through that antegrade approach, now the physician is placing a stent through the opposite direction. So the same territory is being treated. So with our lower extremity revascularization codes, we always pick our most comprehensive code for the femoral popliteal territory. Remember, all of those vessels are considered, or all the vessels there, we only assign one code for the entire territory. We don't have any additional codes. So at this point in time, the most extensive procedure is stent with angioplasty. So that is why you see the set 37226 being assigned here for that combined procedure. Now, we did initially start out with a 36140 for that second catheterization, but of course that gets bundled with the 37226. So the same thing that happened here, the catheter work ended up being bundled with this 37224. Now we don't, even though we had a second access, we're not going to assign a catheterization code. Some of you may be aware, if you have a second access site during a procedure, there are certain times you can assign a catheterization code with these revascularization codes. That only occurs if you have an access that was not used to perform an intervention or any part of the intervention. So if the first access had been only used to do diagnostic imaging, then you would have coded for that separately. But in this case, both the left access and the right access were both used to perform an intervention, one for angioplasty, one for stent. So that's where we have our 37226. Then after there was a clot that was noted in the proximal perineal artery. So then the physician decided to begin a thrombolysis procedure. So it says an overnight TPA infusion. So we know that we have a prolonged infusion that is occurring. So a prolonged infusion is going to be reported with 37211. Now, just TPA administered during a procedure where there is no prolonged infusion, where they don't leave the catheter indwelling for a prolonged period of time, that would not be coded separately. So we see after the stent's placed, now the physician is initiating thrombolysis. We have 37211. So let's take a look at our next page. And I got to turn off the drawing tool to flip to the next page here. So top of page 2, it says the patient was brought back the following morning for for subsequent right lower extremity runoff arteriogram via the right groin sheath. And then down here, we see in the next paragraph that the procedure was terminated. So that second day, we need to report a code for the thrombolysis, which is going to be 37214. So that follow-up imaging that's done is going to be bundled with the 37214. So we're going to report 37214 for day 2 of this particular procedure. And then if we jump down, I just want to point out that we do have findings for that lower extremity arteriogram that recoded on the first page, that's what you always want to check for. Do you have findings for that contrast injection? If findings were not documented here, then we would not actually assign that code. So this is where we see the detail of the findings of the imaging. And then we also have the paragraph that talks about the follow-up thrombolysis imaging, what that shows, but that's all bundled into that 37214. We don't have anything separately to code for that. So those are the codes for this case. So just a quick review. We have 37226 for angioplasty and stenting of the popliteal stent graft. We have 75710 for our right lower extremity imaging. We have 37211 for our day 1 thrombolysis. We have 37214 for our day 2 thrombolysis. And then I've also summarized for you some key points about the coding. A reminder of why we coded 37226. That was because the patient, the indication that we're treating was stenosis followed by thrombosis, which is occlusive disease. That's why we chose 37226 and not 37236. And then I also have a note of why the catheterizations are bundled. Now, one thing I want to point out is that normally you would report a catheterization code with a thrombolysis when you're initiating a thrombolysis. Let's say if the thrombolysis was done in and of itself with no other procedure prior to that, you would have reported the catheterization code. The reason why a catheterization code was not reported for placement of the thrombolysis catheter is because the catheter work was already bundled into 37226 in that extremity. So that's why you don't report any additional catheterization. So the general rule that you want to think about in interventional radiology is if you have two procedures that are being done in the, at the same time, in the same vessel, same territory, or related procedures, and one bundles catheterization and one does not bundle catheterization, you don't unbundle it for the one that allows it. You actually keep it bundled for the one that bundles it. So there's no additional coding there. And then, of course, we have 37211 for that initiation of thrombolysis, and then 37214 for that cessation. So hopefully you learned a few tips from this case, and I'll be back in 2 weeks on YouTube. In the meantime, I will continue to, in between YouTube cases, post shorter cases over on LinkedIn and Facebook for your review. So thank you for joining me, and talk to you again soon.